I just wanted to do a quick intro before we watch the video and turn it over to our esteemed greeters. I just wanted to welcome you all to today's event, Call the Midwife, a conversation about the rising global midwifery movement. And for those of you who watch the television show, you know that that is the best title we possibly could have come up with for today's event. And if you aren't watching the television show, I highly recommend it. It's actually, in my opinion, a bit better than the book. So my name is Sandeep Pathala. I'm the Senior Program Associate with the Maternal Health Initiative here at the Wilson Center. Today's event is brought to you as part of our Advancing Dialogue on Maternal Health series, which works to identify challenges and discuss strategies for advancing maternal health. The series is generously supported by the Maternal Health Task Force and UNFPA. This particular event would also not have been possible without the support of the Embassy of Sweden. In particular, I do want to take a moment to thank my UNFPA colleagues, Laura Laski, Luc DeBernay, Geeta Lal, Mandy LaFleur, Sarah Craven, and Rachel Moynihan, and of course, Katie Millar from the Maternal Health Task Force. For those of you, I know there's a lot of friendly faces in the room. For those of you who aren't aware, the Wilson Center is a formal memorial to our 28th president, and we aim to bring the worlds of policy, practice, and academia together. For the second year in a row, we were voted the top think tank to watch in the U.S. and among the world's top 10 think tanks. So thank you for coming and having these dialogues to ensure that we do have that ranking and rating. Speaking of watching, I wanted to mention that today's event is being recorded. So when we do come to the discussions during each of the panels, I'd ask that you use a microphone and introduce yourself and affiliation so that those who tune in later will know who is in the room. I also wanted to mention the Twitter handles for today's event. I mentioned Call the Midwife, so we're going to use that, and we are also going to be using MH Dialogue in Midwifery if you do want to tweet. The Wi-Fi password is on the side over there, and if you've come to events in the past, that it does get updated frequently, so you might need to reload your username. And I think we are up and ready. Is that correct, Benjamin? And actually, I did take a moment to thank, of course, my colleagues at UNFPA and the Maternal Health Task Force, but the man behind this event today on the Wilson Center side is here to my left. So thank you, Benjamin, as well.
I'm proud with my profession. I like to work as a midwife because I know life starts in the hands of a midwife.
I love my job so much, and I'd want to continue for as long as I can. I would like to see a mother that is delivering in a normal way without any complications. That is a fulfilling thing to me, and it motivates you a lot when you see mothers that are bringing up babies that you once helped to bring into the world.
The population is overwhelming. They really come to seek for services, but you are not able to provide for all of them. The issues of lack of proper working equipments. We do face some challenges, especially in the supplies.
Nikishafika pale asubuhi, nafanya usafi, naandaa vyombo vyangu vya kuwazalisha wakina mama wajawazito na vya kuhudumia watoto wachanga wanaozaliwa. Sawa, nitakuwa naongea. Ninafanya usafi kwa sababu wakunga tuko wachache, kwa hiyo kazi hii inanibidi mimi peke yangu nifanye shughuli zote. Nafanya usafi, naandaa vyombo hivi vya kuzalisha wakina mama. Na bado mama akija, ni mimi huyu inabidi nimshughulikie, nimzalishe, nitunze kumbukumbu kwenye vitabu. Ambapo tumekuwa wengi tungeweza kusaidiana, mmoja anafanya hili na mwingine anafanya.
Those midwives, they are trying their best to work day and night just to give life to the mothers and babies. To them, it's a very difficult situation. But if they can be a lot of midwives and the resources are available, midwives can be happy to work in those situations. And maybe the name which has been tarnished about the midwife can also vanish.
We are getting a lot of mothers. Like in a day you can see 35 mothers. And that is only 40% of the mothers that we're getting. We still have 60% in the community that are not getting the chance to get to our facility. So 40% is overwhelming already. So we need more staff. We need more staff. If I was a leader now, I would like to see that we get more hospitals around. I think the hospitals that we have are very few. The mothers that we have in the community are so many. The few hospitals cannot cater for the many mothers.
Welcome. As Sandeep has mentioned, Call the Midwife, a great title and a great event that we have in store for us today. I'm Roger Mark D'Souza. I direct our programs on population, environmental change and security here at the Woodrow Wilson Center, including our Maternal Health Initiative, which our wonderful colleague, Sandeep Batala, who many of you know and met, directs. As Sandeep had mentioned, at the Wilson Center, we have been recently recognized as the top U.S. think tank to watch, and that's really important because of the type of collaborations that we have. We have a long-standing and excellent collaboration with UNFPA and the Maternal Health Task Force, and I must say to our colleagues at UNFPA, you know, one of the challenges that we continue to have every time we work with you, Laura, is that every time we do an event with UNFPA, we have colleagues who come to us and say, this is the best event you've ever done. So the more events we do with you, the more problems we create for ourselves, because we have such high expectations. And in talking to Sandeep about today's event, Sandeep said it's really amazing. You look at what we're covering today. We're covering all of the dimensions of midwifery, from looking at data to what's happening in specific countries to global initiatives and scaling up. And Sandeep reminded me that when we go through discussions like this, at the end of it, Sandeep said, I'm just going to need to deliver babies. So we hope at the end of the day today that you come out of our discussions very energized and excited and seeing very concrete opportunities for further collaboration, both on the programmatic and policy sides, because this is really what we're about here at the Wilson Center. So thank you for joining us today, and I'm going to hand it over to our colleague, Laura Laski, who's the Chief Sexual and Reproductive Health Chief of the Sexual and Reproductive Health Branch at UNFPA, for some welcome remarks. Laura?
Okay. Thank you, Roger, and congratulations on being named the top think tank organization to watch for. We are happy, and I think that's why we are with you, you know. And together, I think we can make a big difference. And so this is a good event with UNFPA, so we are happy we will continue on that road. So welcome. It gave me a great pleasure to welcome you to this symposium called The Midwife, a conversation about the rising global midwifery movement. On behalf of UNFPA, I welcome you here. I think we are organizing this at a turning point in the global health agenda, where the countries are discussing what exactly they are going to do in the next 15 years in sustainable development. And we are also at a turning point because the UN Secretary General has called for upgrading his strategy on women's and children's health. But also the World Bank has called on organizing and creating a global financing facility to fund the countries who are interested in the area of reproductive, maternal, newborn, and adolescent health. So, but at the same time, we have like 4 months or 5 months to go to we are in the last rush for achieving the Millennium Development Goals. So this is a turning point, and the fact that focusing on midwife, we think that's a way to go in terms of strengthening the health system, in strengthening the health system, because for achieving the Millennium Development Goals or any other goal, we have to focus on the human resources for health. And for women, children, adolescents, this is an agenda that we really care for. They are the workforce that will deliver for women and children, newborn and children. So we organized this to carry forward the ongoing conversation about midwifery. We want to share what we have learned on midwives around the world. And so we also want to demonstrate the role of public-private partnerships on innovations and what the field can benefit from on this area, and use this opportunity to strengthen our partnerships here in Washington, D.C. So with that, I am very honored to welcome His Excellency, Mr. Björn Liervall, Ambassador of Sweden to the United States, to this event. Prior to assuming his current role in September 2013, Ambassador Liervall was Director General for Political Affairs at the Sweden Ministry of Foreign Affairs in Stockholm. Ambassador Liervall has served as Sweden's permanent representative to the European Union in Brussels, as well as the United Nations Special Envoy on the Balkans in 1999. Sweden has been a worldwide leader in supporting the midwifery movement, and we are very, very thankful to Sweden for the support that specifically has given to UNFPA. They have more than 200 years of experience in supporting midwives with excellent results, and we are learning from Sweden still to these days. So let me express our sincere thanks to Ambassador Liervall and welcome you to the podium. Thank you.
Well, thank you very much, Laura. Thank you very much to the UNFPA for an excellent cooperation, and to the Woodrow Wilson Center, Sandeep, and to Roger Mark for your work here as well, sterling work of your center. It's always a pleasure to come back here. I'm spending a lot of time in this building with various events of the Wilson Center. Well, I'm honored to be here also to add a voice, a word from my government, from Sweden, to this important symposium. I think that we, with today's event, hope to be able to spark additional engagement and also reinforced discussion on the benefits of investing in the midwifery workforce. And I can tell from the agenda that we have for today that this is going to be very substantial and a very important day, and obviously my government is very proud to be part of this symposium here today. As Laura said, and as some of you would already know, Sweden has a long history of investing in midwifery. It started out already back in 1751 with a report to our parliament at the time that out of 651 cases of women dying in childbirth, 400 could have been saved if they had adequate access to a midwife. At that time, the maternity mortality rate in Sweden was among the highest in Europe, with about 900 per 100,000 live births. And 1 century later, Sweden's maternal mortality rate had decreased to 230 due to the presence of midwives trained in safe delivery techniques. And then over the following century, investments in midwives was an important part of building our welfare state. And Sweden continues today to invest in midwifery both nationally and internationally, because we are convinced that this is the smart thing to do. Investing in midwifery is not only economically sound, it also saves lives, but it also transforms societies to value women's health, to value human rights, gender equality, and it contributes to sustainable development. And in our view, the facts are clear. The evidence is there, but still the world is not investing enough in building up a professional cadre of midwives. And why is that? Well, I would say that this has mainly to do with the lack of political will and gender inequality, but in some cases also a lack of resources. And that is a problem, and the good news is that the situation has improved and we can continue to improve it further. The UNFPA plays a crucial role in this continued effort. Since the UNFPA started working on this back in 1969, the number and the rate of women dying from complications of pregnancy and childbirth have been halved. And we do see a remarkable improved situation in many countries, but there are still major challenges. And one of the most difficult aspects of reducing maternal death is finding ways to reach all women, even those in the poorest, the most remote areas, or in times of natural or man-made disasters. This involves bolstering health systems and making sure pregnant women can access all the care that they need. And we will need to work together to find means to make this a reality. To this end, my Ministry for Foreign Affairs, the Swedish Ministry for Foreign Affairs, has recently launched a campaign for change, and this campaign is called Midwives for All. And that's another hashtag. I don't think we had that hashtag up there. But remember that hashtag as well, Midwives for All. And the purpose of Midwives for All is to get more people, more organizations and stakeholders to actively advocate to ensure that more people have access to a midwife when they need one. And this effort also ties in with the objective of today's exercise to find new and collaborative ways to foster partnerships that can scale up midwifery, something which will be of benefit to all women, but also to men and our global society as a whole. So with those words, let me just wish you a very fruitful discussion here today. I look forward to taking part of the results and your ideas for further boosting the rising global midwifery movement. Thank you very much and have a good day here.
Is this your copy? Do you need help? No, I think the panelists are going to come up. You want to invite the panelists?
So can we have the first session's panelists join us up front? And this first session is on data. What does data on midwifery say? Luke is here. I think Holly is here.
Holly, and then Francis is here.
We took on the, we took there or we took from where?
I think we'll give you the choice. So, yeah, if you could, that would be great. Okay. Good.
It's an exciting day. We have a lot of panels. That also means we have quite a number of PowerPoint. Just bear with me as I bring up the correct one.
And can I get started while you're?
Yeah.
Okay, let me just get started, everybody, so we're not wasting any time. We have a huge agenda today. I'm Peter Johnson. I am the Director of Nurses and Midwives and Global Learning at JPIGO, an international NGO affiliated with Johns Hopkins. And I've worked very closely with my panelists here on supporting midwifery workforce development over the past several years. And it's my honor to introduce Luc de Berny, who has been with a career at UNFPA, and I understand we'll be losing you in the next couple of years.
Of months.
These things are flexible, right? And then Holly Kennedy, Dr. Holly Kennedy is professor of midwifery at Yale University, and I think I've worked with I've worked with Holly and known her most of my career, so to be here at the Global Forum is very special and exciting. And then Frances Day Stirk, who is the current and two-term president for the International Confederation of Midwives, also another close collaborator over the past several years. And I'm thrilled to be with such an esteemed group of individuals and like-minded friends. So let me start out. We're going to go in order, and I'll start with Luke. And Luke is going to be speaking to us from the perspective of evidence gained through State of the World Midwifery, most recently in 2014. And I hope you may also say a little bit about experiences from the High Burden Country Initiative, which I know was a labor of love over the last few years.
Thank you. Thank you, Peter. It's working? Yes. Thank you, Peter, and good morning. It's a great pleasure to be here. Great pleasure to present to you a very great report with great data. And it's also great to contribute and continue to work on this movement. As Laura was saying, long day on midwifery, promoting quality of care, center on the woman and the newborn. I think I have to move myself. Huh? And do that. I said great report because it's quite exceptional to have a report which is the achievement of 74 or 73 exactly country teams working in the field and developing this report all together. Thanks to ICM, and Frances is there, it's a great pleasure. I thought it was not working well. Okay. Yes. How to do that? It's like this. I don't know.
I can also advance for you if you'd like.
This one?
Yeah.
No.
I'll get that checked.
Sorry. Okay, I will do that myself. Okay.
So I was saying, sorry for the interruption. I was saying that this is the fruit of a great collaboration, particularly at country level, between the Midwife Association that we really try to put on the front with WHO and UNFPA. WHO is not there, unfortunately. And it was also done with a great support, the technical support of Integrare, which is a group of experts which were extremely useful. You can go to next. I just go briefly to the main findings of the report because I would like to explain to you. The question is what data say, and first of all, I would like to say what the report say, and I hope you have been already able to read at least part of this report. But then we will discuss about what data say, and I will tell you that a lot of data is still not exploited. When we are working with regions and different countries, for example, we are analyzing and making secondary analysis to show what can be done in terms of comparison, comparing countries between each other, comparing regions each other. This is an ongoing work. So a lot of results. The main, I don't know if you can read very much, I just pick up some. The first is about the fact that when we are talking about 92% of maternal death in the world, represented by these 73 countries, only 42% of the health workforce is available in these same countries, already an enormous gap. The second is that only 4 out of these 73 countries have already the workforce which will enable us to respond effectively to the needs of pregnant women and a newborn particularly, but also for family planning. The third I would like to insist on is to say that, and particularly this is also the collaboration of the Lancet series on midwifery, and I think the complementarity here is very good, that 87% of the essential interventions listed by PMNCH and WHO can be achieved, can be provided by well-trained midwives. This is absolutely critical, and this is, reassuring us that it's definitively the right choice to work on the mid-level cadre which should be accessible for any pregnant woman and newborn. The sixth one is also an interesting topic, because the report is not only to have a report. The report is part of the movement, as I said, and the movement is at country level. The 73 teams working on this data realize all the gaps and the difficulties for them to have the right data. The Department of Human Resources for Health at Ministry of Health are, in general, very weak, very badly supported and equipped. So the people work on the data and discuss, met all together to discuss, and this is part of what we need to see in each of the countries. And one lesson is that if you have 10 items, you can really look at the situation, at the map of midwifery workforce, and then you can advise in terms of planning for improving this workforce. And let me talk about that briefly also, because thanks to the colleagues at the World Bank, calculation made in Bangladesh of investment in training competent midwives, if they are on the field for 30 years, and if they are effectively deployed, the calculations show that the return on investment is absolutely one of the best in the world, because it's equivalent at immunization, which is absolutely fantastic, because for the moment we don't know better return in investment for health. Thank you. We use for this report, in order to analyze the situation without missing anything, the human rights framework, and you know that with the four pillars: availability, accessibility, acceptability, and finally quality. Let's go. I will go very quickly through different points. Availability. In general, in the data that we can find, you count the people who have a role to play on maternal and newborn health. And you have a number of people, and countries move with that. But if you look at what exactly the people are doing, you will discover that few are spending 100% of their time in delivering care for sexual reproductive health, and particularly maternal and newborn health. Majority are delivering this care for 20%, 30%, 40% of their time. So if you look at the equivalent in 100 full-time, then you go to this graph and you see the difference. This is exactly what in reality is the workforce dedicated to babies and mothers. I will come back on that later. Accessibility. We know that it's not only geographical, which is still an enormous problem in countries. I'm just back from the 3 Ebola country where they have a lot of disseminated population and few facilities inaccessible geographically by the woman. But the financial access is also probably the most important. And this report provides you with a number of data regarding the financial access. We know that the inequality exists, and each government can look at the exact data. And as I said, we are working on comparing the different situations. This was done when we were working recently in Geneva with the Francophone countries to see what are the differences. And here, in financial accessibility, by the way, the difference is not huge. In other items, it's largely bigger. Acceptability. The report is not extremely rich on that. As I said, the fact that people were working on the data and meeting together gave them the opportunity to talk about acceptability. Difficult to put the acceptability as data. And what we can say at this moment is that more research certainly is necessary. More research is ongoing, and what we can say is that if we compare to few years, and we discuss that with Frances very often, in few years it was midwives were reluctant to talk about that, and now it's really a top topic for the Midwife Association, which is very encouraging. Quality again, I come back to this graph. Quality is also something complex. Quality is based on availability, accessibility, and acceptability, obviously, plus other items that we need to look at. When we try to find ways of addressing quality, let's look at this one. It's one example. You have the head count, you have the 100 full-time equivalent people, and then we have the training. Are they able to deliver all the scope of interventions or not? And you see the reduction. But if you add that the quality of the training was good or not, and we take one indicator, could be discussable, one indicator which is the number of childbirths supervised directly by the student during the education training, you see that the difference at the end is 90%. So when we are talking about not only the number, but the quality, we need to look at this type of indicators. And this is also addressed in the report. Another issue of quality, which could be combined to others, but if you compare between the Francophone and the general world, you see that in the Francophone countries, many of the new trained midwives are not recruited and can wait for years before being really effective in the ground and losing a lot of their training and capacities to deliver good quality of care. So this is the type also of indicators that we are presenting in this report. Now, a very important part. For each of the 73 countries, you have a two-page which includes a lot of data. So this is an example of Afghanistan, and I will certainly not discuss all that, but this is to present you how the report is structured. And then when you go, oh la la, okay, this is, okay. When you go to this report, you see that we are looking at the pillars, as I was mentioning. The current needs, we calculate the intervention necessary to cover 100% of the needs in terms of antenatal care, childbirth care, postpartum, and family planning. You see, for example, in this example, no, we cannot see here, but you have the percentage of the current coverage by intervention. Then you have availability, accessibility, and quality. And then you have projections. And I would like to insist a little on that because the time is very short. So you see here the projection of the population growth, the number of childbirths per year from now until 2013. So we work on this 15 period of time, 15 years that we are in front of us. And you see that in this particular country, I think it's Chad, you see that if the policy is still the same, the coverage is already extremely low, and if with the population growth, the coverage will decrease. So we have done, we have done projection, and we have proposed 4 ways of moving. First of all, to increase to decrease the number of pregnancies. So an efficient family planning system with 20% reduction of pregnancies until 2020. The number of midwives, we double the number of midwives. We increase efficiency 2% per year, and we improve also the attrition. And we see what happened from now to 2013. And you see the difference here, where in this case is also extremely bad, but this is what a number of countries are facing, particularly in sub-Saharan Africa, and particularly, but not only on the Francophone country, where we are extremely worried about what will be the situation in 2030. So this report is giving you not only the situation currently and the challenges that countries are facing to increase the coverage, but giving you and the countries the challenge that they have, and showing that without a clear political will of moving the things for mothers and women, and also if the international community is not mobilized to really support particularly those facing the major difficulties, we will not achieve the 70 per 100,000 live births international agreed goal for MMR in 2013. So as a result, if you look at if we don't change anything, you see that 37% of country will stay with a huge and unmet need for midwifery workforce and coverage of the essential interventions. If we change, but very dramatically, and we have to realize what effort has to be done to really achieve that, we can achieve an enormous work, but still, despite what we are proposing, 70% of the country will be really in a bad situation. I am finishing, showing that we have classified all the countries based on this analysis of projections of what can be done in the next time, and we see low met need, expected met need, medium, and high met needs. And the green countries are those making progress, and the red countries are those going backward. So you see that in this group, despite countries very well supported and with strong programs like Ethiopia, you know, but we have Burkina Faso, which has very good reputation, is moving forward in reducing maternal mortality. If we don't give attention, all the gain done today will not be still there in the coming years. So it's not because countries seems to do well now. If we don't invest strongly, the things will not be sustainable. And I'm finishing here, and sorry to be so a little on a rush, to thanks all this coalition of partners. Without them, the work would have not been possible. Thank you very much for your attention.
Thank you, Luc. Luc took a little extra time, but I think that it was very, very welcome in terms of getting us off to a good start and how you can make your way up to the podium. Well, I'm saying that I think it's pretty clear that Luc's passion for midwifery has been is palpable, but it's also been steadfast. And one of the things that I should have said was that Luc was honored by ICM and at the meeting in the Czech Republic last year as for all the work that he's done as an honorary midwife. So we have all midwives up at the table.
Thank you, Luc. It's an honor to be here to talk about the Lancet series and the evidence that we uncovered in this very interesting partnership. Luc was one of the co-authors on some of the papers, and so what I'm going to do today is talk with you about what we found and to discuss where we should go in the future. The Lancet series in midwifery started about 3 years ago. Luc and I think some others in this room gathered in Barcelona for a week and began to work on how we could map the evidence on midwifery and what that could show. It was funded by the Bill and Melinda Gates Foundation. The aims of the series were to examine comprehensively and systematically the contribution of midwifery and what it can make to the quality of care of women and infants globally. And then the role of midwives and others providing midwifery care. And I'll talk a little bit about what we mean by that. Some of the challenges in the evidence about midwifery is that the evidence is not completely apparent, particularly in low and middle income countries. The inadequate quality of some routine data that are collected, the focus on specific interventions versus a wider vision of what midwifery can do in practice. The components of the experimental and control groups not particularly well described in some studies, so you're really not sure what the outcomes are and what's causing the outcomes. And the measurement, difficulties with measurement and how you get to those outcomes. The authors were a broad group of clinicians, analysts, demographers, statisticians, policy experts, around 35 of us who developed, at the end of the day, 6 papers, 4 of which were published in the series, 2 of which are in development and will be hopefully coming out later this year or early next year. We had close and very critical readers from WHO, the Gates Foundation, ICM, FIGO, Lancet editors and reviewers. So Luke, I would say it was one of the most challenging experiences I've ever had in my career. So we're delighted to be able to share the results with you. I'm going to share the evidence from 3 of the papers. The 4th paper was more of a summative paper, and then talk very briefly about what the next 2 papers are about. So the first paper used a step-by-step approach to define midwifery and map its scope, to develop a framework of care needed by childbearing women and infants, by all childbearing care women and infants, to identify the what, how, and who of midwifery, and to use that as an analysis for the evidence. So the sources of evidence we used were 3 reviews of reviews, women's views and experiences of effective practices in care providers. We looked at 13 metasyntheses, 461 Cochrane reviews, and 7 high-quality systematic reviews of workforce. It was an amazing undertaking, I have to say. And then we had 3 case studies of middle-income countries in transition, Brazil, China, and India. So this was, euphemistically, we called this paper 1. So if you get the Lancet series, this is the first paper in the series that really looked comprehensively at all the evidence. And then we mapped it with the ICM competencies. So this is our definition of midwifery. We spent quite a bit of time talking about, are we talking about midwifery or are we talking about midwives? And in the end, we believed that we were talking about what midwifery is and what it can do, and that it is provided by midwives, but it's also provided by other providers. The areas in red are what we felt were some of the most important aspects about what midwifery is, that it is a care of women across a continuum, that the care that midwifery is optimizes normal biological, psychological, social, and cultural processes, and that it strengthens women's own capabilities. This is the framework. I think if I can just show here, these are the the laser do that? I'd have to. So if you look at, this is practice, how care is organized, values, philosophy, and care providers. If you look at all of that, that is what midwifery is in that highlighted box. And this area right here is what's needed for just a small amount of women. This is what all women need, and this is what just some women need. All right. So this is what we found. 56 outcomes improved by midwifery of maternal and newborn mortality. Fetal loss is reduced, less preterm birth, low birth weight. Maternal morbidity is reduced, reduced interventions, improved psychosocial outcomes, increased birth spacing, increased breastfeeding, and shorter hospital stays. The framework can be used and tested in a range of contexts, and midwifery is associated with positive outcomes, especially when midwives are educated, trained, regulated, and integrated within a teamwork. The second paper looked at what would happen if we scaled up midwifery around the world. I have to say this is my favorite paper of the series. And we wanted to look at if we improved the effect of midwifery care, and the authors used the Lives Saved tool list to estimate what would happen if we increased. They examined 78 countries that accounted for 97% of maternal and 94% of neonatal mortality. And what they found was that in the low Human Development Index countries, if a modest 10% scale up of midwifery, you would reduce, that included family planning, and as Luke mentioned, family planning is incredibly important. You would reduce maternal mortality by 27%, just a modest 10%. Substantial 25%, 50% improvement. And then universal coverage of 95% reduced by 82%. And this just gives you a visual look at it as the first This is the modest scale up, substantial scale up, and universal scale up, and that goes up even more with family planning. The third paper looked at 4 countries, Burkina Faso, Cambodia, Indonesia, Morocco, and I just want to just show you how this, what they looked at here. So they modeled countries that had a sustained and rapid reduction in maternal mortality over the past 20 years. So the mortality rate is coming down compared to those where it did not have a substantial. So you can see how chaotic this figure is. And then they looked at the countries that at the same time had an increase in midwifery services. And they pulled 4 of those countries to do case studies on. And if you look at this, Indonesia, Burkina Faso, Morocco, and I'm going to block on the last one, Cambodia. So this was an example of, you need to go to the series and read this, but this is an example of the complexity when you look at scaling up midwifery in a country and the outcomes of looking at how the systems are developed and what's happening. So they looked at all the things that happened in the increase of midwifery schools, free public facilities, investment in basic health and hospital infrastructure, and all of those. So it's a very fascinating exploration of those 4 examples where midwifery was scaled up and changes happened to improve outcomes. And then this is an example of the 4 countries, and the pink line is the investment of midwives, and the purple line is the increase in services, the integration of services. But I think it's very interesting. Indonesia really had one of the marked changes, and you look at that pink line of the investment in midwives. And what is it, 2020, Frances, that we're going to be there?
Yeah.
Right, for the International Confederation of Midwives is going to be in Indonesia. All right, almost done. So at the end of the day, I just want to come back to one of the most important factors that we found, and that is that that midwifery comes within a framework and integrated within a country where it's the midwives are educated, trained, regulated within the system, and an effective teamwork. And in closing, we are working on 2 other papers. What's now called Paper 6 is really looking at respect and abuse in the care of women. And then in Paper 5, and some of you in this room will probably get this from us fairly soon, we are doing a research prioritization. So we took all the data from the 4 papers and looked to see where the gaps are, and are doing a process globally to pick out the top 10 research priorities for future research. So thank you.
And while Frances is coming up, I just wanted to just point out in this remarkable, quite remarkable series on midwifery in the Lancet, I think what might be most remarkable after giving it more and more thought is that very succinct definition of midwifery. I just want to give you guys a lot of credit because I was thinking about it again this morning, and you almost boiled it down to a tweet.
Those red lines, yeah. Didn't take.
It
took a lot longer to get to that.
Which is a world achievement to become a tweet.
I am sure that it took a lot of work around the table. Frances.
Right. Thank you, Peter. Good morning, everyone. I'm Frances Day-Sturck, president of the ICM, and we're really delighted to be here. I've been asked to talk about the ICM's vision and a bit about our programs and so on, and I'll do that, but a little bit more. I've called our talk A Promising Future because this is the title of our strategic direction for the triennium 2014 to 2017, and we are looking very optimistically towards midwives being, these are my words, I've stolen it from HBSC adverts, but midwives being a norm and not the novelty. So what is the ICM's vision? Our vision is a world where every childbearing woman, and I've put girls in here as well, because although we want girls to be educated and have access to contraception and so on, we know that in many parts of the world, they don't have any choice, and we want to make sure that they too have access to midwives. I want to go back. The way that ICM works is through its member associations, and because they are the people who have to drive and lobby and negotiate in country. And so we spend our time working with member associations to develop those capacities. Well, why call the midwife? I am pretty sure that Jennifer Worth, who wrote this book, A British Midwife, had no idea of the impact it would have across the globe. It's a bestseller, and you know that BBC has made it into a series. It's reached the ears of many people in many parts of the world, including the UNFPA Executive Director, Dr. Babatunde Shotimin, because I heard him with my own ears in Geneva talk about the midwife and what a polymath this midwife was. And I think this series has done an inordinate amount for the public and others understanding the scope and the capacity of midwives when they are educated, regulated, and supported. So why call the midwife? Because they are appropriate when they are adequately educated and regulated, and you've seen and you've heard from Holly that this is supported by the Lancet series. Midwives tend to be where women are. They are accessible, more accessible to women, and in many parts of the world, they work in poor geographic areas and environments where many other providers fear to tread. They're cost effective, and you heard from Luke of the findings in the SOME report about the 16% return on investment. It's a very cost effective intervention in terms of sexual, reproductive, maternal, and newborn health. But we do have a problem, and you've heard about them being able to deliver the 87% of the 46 essential interventions. But we are very short of midwives. And we're short of midwives across the globe, but primarily in sub-Saharan Africa. I like to think about the midwife effect, and you've seen from Holly's presentation, but we've had this evidence going back years. That's Sweden. And you can see the maternal mortality in Sweden in relation to the proportion of midwife-assisted home birth between 1861 and 99. And here's the death rate on this axis. And as midwives were introduced, you could see that the maternal mortality rate and the newborn mortality rate plummeted. But in the 60s, they also did some work around the same sort of interventions in Thailand, Sri Lanka, and Malaysia. We get the same picture. We've known this for ages, but there hasn't been the political will to activate it. There's a piece of work done by Luden in 1992, and he attributed the decline of maternal mortality related to both the increasing the proportion of midwife deliveries and to higher standards of midwifery. And the authors of Investing in Maternal Health, Learning from Malaysia and Sri Lanka, describe the critical strategies for reducing maternal mortality ratio as professionalizing midwifery, monitoring births and maternal deaths, and high-profile advocacy. So what does ICM do? So we reach out. We engage politically with governments, and we advocate for strengthening of health systems. We provide advice for midwifery education, regulation, and competencies for best results. And we advocate for financial investment in midwives and midwifery. And that's in a totality in terms of their education, their employment, their deployment, having good environments in which to work. And we collaborated with a number of partners to raise credibility and the visibility of midwives worldwide. So midwives work, as you can see, wherever they're needed, wherever women are found, and that's where midwives work. We have worked and used critical foundations for the last, since 2009, 2008, the pillars of education, regulation, and association. And they're all underpinned by essential competencies. And for those of you who are not familiar with the ICM essential competencies, you can find them on our website, but there are 7 domains: social, epidemiological, cultural, and context of maternal and newborn care, pre-pregnancy care and family planning, care during pregnancy, labor, care for women during the postpartum period, postnatal care of the newborn, facilitation of abortion-related care. They're quite broad. Just a couple of our programs that we're running currently. We're working with UNFPA again, this time around the Francophone countries. There are 21 countries that we'll be working with, including gap analysis, workshops, and that's all about strengthening midwives, strengthening midwifery in those countries. There's a picture of the midwives in the Comores, where we had the first workshop last November, October sometime. Yeah. What ICM has done is between 2010 and 2013 developed a number of resources, and they're all listed down this side here, and they're easy to find on our website. For 2015, we will be bringing out our regulation toolkit, and again, this will help countries and midwives associations to, it's a practical approach. How do you do this if you have regulation that doesn't exist, or you have regulation that needs to be strengthened? We also will have this year, very soon, the Midwifery Services Framework. This has been on our agenda for quite a long time, but it's going to be born this year. Rima will talk about it in detail, but just to say that this is an ICM initiative. It's innovative, and it's the first time we've put our toes so deeply into the human resources, the workforce issues, and we're really looking forward to this. It will provide a framework to help countries to apply the evidence and the standards to improve their policy and programming around human resources for health. And we're also working with Ladle Global Health in 2 countries, Zambia and Malawi, on helping babies breathe and helping mothers survive. Now, I've got 3 minutes left, and I've rushed through all of that because I thought I'm going to be late. But I just want to say a little bit about the workshops that ICM runs with countries. And it's about helping countries to find their own and enhance their technical abilities. It's about aggregating midwives' efforts and influencing policy at local level, because that's where the change has to come. It's about positioning and professionalizing midwifery and midwives for visibility and impact. And that's very important, because in some parts of the world, a person who's called a midwife might have 3 months education. That's not a midwife in ICM's eyes. A midwife is someone who meets the definition of the midwife, who's educated, who is able to work autonomously and within a team. So that's our main goal. I'm going to finish soon. I just want to say that none of this will happen unless all of us in this room work together. None of us will happen unless countries begin to value women. The gender divide is huge. And if you look at the countries, I'm going to use the Scandinavian countries, who have enjoyed, Sweden over 300 years of midwifery. Denmark celebrated 300 years of midwifery regulation last year. Norway, I'm not sure about their regulation, but they've enjoyed such a long period of valuing the profession of midwifery, valuing women, valuing the education of women. And those are the key elements in making maternal and newborn mortality decline and reaching the goals for 2030. I want to say thank you, and I wanted to leave Sweden with the last word, and this is Anders Molin at the ICM in Prague last year when we launched the State of the World's Midwifery Report, and you heard it from the ambassador today, and whenever you go anywhere, you'll hear it consistently from Sweden, that midwifery is a system we have chosen, not because it's the cheapest, but because it's the best. And I really like the Midwives for All campaign because it actually mirrors the ICM's vision. A world where every woman and her newborn has a midwife for herself and her newborn access to. Thank you very much.
Thank you, Frances. And I understand now that we have a quick video to show before we go on to question and answer.
The World Health Organization has been requested by member states to prepare a global strategy on human resources for health by 2016. In parallel, the UN Secretary General is requesting a revised update to the Every Woman, Every Child strategy. These two processes offer unprecedented opportunity to ensure alignment on the health workforce requirements and the midwifery workforce requirements. Today's Geneva Dialogue is an opportunity to ensure we align these two processes.
The work of a midwife, to me, really is a starting point in building a strong and resilient health system.
Strengthening and consolidation of midwifery service can make a huge difference in delivery of health services to women and children.
Midwives are not a luxury. Investing in midwifery workforce is not only about achieving quality care at childbirth, but also about ensuring progress towards universal access to sexual and reproductive health for women and adolescents. So without a competent workforce there can be no quality healthcare services. And a competent workforce requires the participation of midwives. In fact, midwives are central to that.
It is absolutely vital for our democratic countries to combat maternal mortality and neonatal mortality must be considered today as a social investment and a vital economic investment.
Interventions in health facilities alone will not reduce maternal mortality. You need improvement in the quality of care, of course, especially maternal care and emergency services. And you need midwives to play that critical role.
Human resources in the health sphere are the cornerstone of the healthcare system, so we need to invest in this strategic area, and that would really ensure substantive improvements in the healthcare sector.
International monetary funds, the World Bank, need to address this issue and need to revise the policies for development.
Educating and training midwives is one of the most important things that the government should do when it comes to healthcare.
If investments are made at the right point, we can provide a minimum package of care for every person.
Improving health outcome, we need midwives, we need midwives, we need midwives. So I repeated 3 times to emphasize the important point.
Ambassadors and heads of agencies have clearly given us the evidence and the rallying call for action. We need universal access to sexual and reproductive health, universal health coverage, and universal access to a healthcare worker.
Okay, well, thank you. We have nearly 25 minutes for question and answer before our panel time is finished. I think there's a microphone to pass around. I'll take a few questions at a time, maybe 3 questions at a time for the panelists. In the meantime, while we're getting that ready, I just have a question for you, Luke, and that is, we just heard Margaret Chan say it 3 times for emphasis. How is current evidence supporting the effectiveness of midwifery care being used to promote midwifery as part of the 2030 agenda? We're hearing a lot about universal health coverage and how are we going to get there. I'd like to ask you if you could talk specifically from some of this in-country work you've done, particularly with, with SOMI, but also with the High Burden Country Initiative, where you've taken a more detailed look into certain countries that really need midwifery most and maybe are struggling a little bit more than others. And where are the priorities? Where are the places that we need to invest perhaps first or most?
Difficult question. Thank you very much, Peter, for this. Effectively, we are trying to work with countries. As I mentioned during my presentation, the work of the report was not just to produce a report. The work was to support and strengthen the movement at country level, involving all the key actors. What we are doing also is to be available for country. We want really to look at their midwifery workforce. And for that, with WHO particularly, and also other group of experts, we have developed what we name a midwifery workforce assessment. And the handbook, which is summarizing this methodology, has been just issued after long gestation, after revision based on the country experiences. We have now available for any country we want to do this type of analysis, a really good methodology, which can be a long process, but which can be also done in a few weeks in order to really guide. And it's particularly important at the time, as we said, many countries, and this is a good signal, are revising their midwifery workforce or their human resource for health workforce. After the Ebola crisis, all the 3 countries put human resources for health as a first priority item for the revision of their national strategy for strengthening the resilience of the health system. So I think we are very good signals. Now we have at least 2 countries, we have done a very comprehensive assessment of their midwifery workforce, which is Bangladesh. And this report is used as political level. And this has been extremely important when Bangladesh was hesitating between training low-level cadre, cheapest, and to spread this type of cadre, to complexify a little the situation. When you see the number of countries with different type of mid-level cadres normally made to support midwifery and the pregnant women. So Bangladesh has decided to go for a fully competent midwife based on ICM competencies, and this is an excellent thing. And Tanzania is very close to issued a report also, which is a comprehensive analysis. So I think it's a movement. It's long, it's difficult, but with this new methodology available for all, and knowing that some countries are already expressing needs for this type of analysis, we are very optimistic that definitively the midwifery workforce will be as a key item on the post-2015 era. Thanks, Peter.
Thank you, Luc. So if we could please direct any questions and comments that we have to the individual panelists, that would be great. Donna Vivio.
Hi, I'm Donna Vivio.
The microphone behind you, Donna.
Good morning. I'm Donna Vivio from USAID. Is this working?
Mm-hmm.
I'm
It's working.
technology impaired. I'm sorry. So given the discussion this morning on midwifery and midwives and the need for a midwifery workforce, and now, Luc, what you just said about Bangladesh and electing to go the full professional midwife course. I've been in a number of countries, and I know that governments struggle with this because they want something now. So can the panel, whoever on the panel would like to address this, please comment on what countries can do to get the midwifery skills that they need while they're building up their professional midwifery cadre? Thank you.
Okay, and one more question? Yeah, it looks like we have microphones on both sides of the aisle here.
I don't think it's working. Oh, okay. My name is Kim Trout, and I'm a member of the midwifery faculty at the University of Pennsylvania. And if I could just piggyback a question on top of Donna's. In particular, I'm interested in that category of auxiliaire midwives. Where do you see them fitting? Because I know there's controversy whether they actually meet ICM competencies. I mean, and these are programs, say, 12 months in length, not 3. So I'm curious what your thoughts are about that.
Okay, so panel, I'll let you take it in any order you want. Who wants to respond?
I'm going to kick off. Thank you for both the questions. You know, we've seen in ICM over the years, countries investing, and I'll give an example of a country, in 17, for example, different cadres of midwives. Complete waste of funds, because not a single one of those cadres was able to deliver the full range of services adequately and competently. I'm very pleased to say that that country now has got a single professional midwife, but also an auxiliary. So they only have 2 cadres now, the professional midwife who supervises the auxiliary cadre. And it does take time, but it's about recognizing that you do want to achieve this professional midwife and you plan for it. And some of the work that Luc and others have done around the HB, High Burden Country Initiative, will show that if you plan it out, then you know where you are at, but you have the steps to reach the professional midwife. It does take time. But women do deserve to have that care. And I often think, you know, many of us have got on a plane to get here. When we get on the plane, we expect that that pilot is competent. He knows how to take off. If he or she meets a problem midair, they know how to handle it, and they know how to land. So would we like to get on a plane where the pilot doesn't know what to do if he meets an emergency, and he doesn't know how to land, so we're stuck up there forever till we run out of fuel? And I think at a simple level, that's what I certainly would say to countries, that it's an investment worth making, and we have the evidence for it now from Bangladesh. Holly.
Thank you, Frances. That's a great analogy. And I'm sure there are women that have sometimes thought, when am I going to land? So I was fortunate enough in 2011 to be the president of the American College of Nurse Midwives and present at the ICM Congress when the 3 pillars were passed. And one of the most poignant times of that debate, and there was a lot of debate about this level of education and what ICM was proposing. And a midwife from a very low resource country got up and said, there is no way my country can do this. But we are voting for it because this is where we should go, and we can give this to our governments to say this is what women deserve. And so I would say for those countries that want to do it fast, there's a wonderful African proverb that is, if you want to go fast, you go alone. If you want to go far, you go together. And I think it takes more than a village. It takes your whole country investing in this. Women, families, governments, ministries, educators, everybody working together on it. And the ICM's given us tools to make that happen.
Yeah, if I can just take a very quick, if you don't mind, Luke, just a quick perspective on what I think is a really important issue raised by Kim and Donna. I think it's health systems, and I wish we would put more of a health systems lens on the work that we're doing. It's incredibly frustrating for me when I see us educating midwives when there's a 50% deployment rate, and 3/4 of the midwives that are being prepared in some settings are not giving us any return on that investment. I think we need to be thinking about the big picture, things like, what are the appropriate selection criteria in relationship to retention and ability to serve the community. But that said, it's a long, hard slog to get there. And from a donor perspective, Donna, I think there's reluctance sometimes to make the case. Even on our part, for making these long investments when the results of that are expected by the donor are not going to be measured very easily within the context of a 3 or even a 5-year project. Sometimes the results of educating more midwives won't be seen for a decade or even longer. If you look at the roots and the foundation that we need to lay down. So I'd love some discussion around those issues as we go through today. So.
May I just complete briefly? And I would like to echo what Holly was saying, as well as Frances, that it's at the end of the day, it's a political decision to work to support women's health in general, and I would say to address this gender inequality in access to health. And this is why the data is so important. So thanks to the organizers to put at the start a discussion on the data, because, and Oli said that it has been a very big challenge for all of us to work on this Lancet series, particularly because we were starting from I don't know, not too much. We were looking at us saying, okay, what do we know? So we started with a definition, because without starting with clear definition, it was impossible. And the reason why the framework is so important, because this is, I think, the first time, at least in my knowledge, where we have a very clear vision of what we are talking about. And so it's also all the work that Holly is leading on putting research in the front and research done by midwives. How many midwives are yet able to conduct research? Very limited, and particularly in the developing world, to find midwife with a PhD or to find midwife with some education able to lead some simple research is extremely difficult. So we have still a long way to go. Dana was talking about the fact that governments want to results immediately or very, very quickly. We understand that, and this is legitimate. Okay, let's say that we know that. So we need to be clear, and I think it's our responsibility to be clear about what we are proposing. And still, as Frances was saying, many countries are struggling with strategies which are not effective because they don't receive probably the right advice that they need to receive. So we are becoming clearer and clearer. Many countries are developing parallel strategies. For example, they have a lot of nurse midwives or nurses, and they decided to take part of these nurses to become midwives with a short 18-month training. At least you make a progress. But in parallel, we need to convince them to have also a direct entry midwife training and education, which will allow them in the long run or middle, not very long run, 3 years, I'm sorry, when the women are suffering for decades about lack of quality of care, waiting for 3 years to have well-educated midwife and disseminated, please give me a break. This is something that any government can take it. So we can combine strategies and serve the needs of the politicians to show results, but also to ensure that on the long run we have good strategies in place. Auxiliaries, it's very important because you maximize the efficiency of a midwife if she is working with a small team of well-trained auxiliaries. There is no indication, there is no international consensus on the duration of the training of auxiliaries. Many countries are training them in 1 year, around 1 year. But there is no rule for that, and we have to support. But for midwife, it's absolutely essential. Midwife should not work alone. They work with a strong link with comprehensive emergency obstetric care services. They work with communities, with community health workers, and they need to be supported in their facility with auxiliaries. One of the innovative solutions that we need to propose is to promote midwife-led maternities. And this is a move because Frances was talking about the fact that the profession should be an autonomous profession. So midwives can stand up and do their work supported by the system and not stopped by the system. And we need to demonstrate that if midwives are fully trained and develop the 87% of the essential interventions that are needed and recognized as important, we will do a very good step forward. Sorry, I'm talking about the Ebola countries too much because I'm just coming from them. But what we are proposing to change dramatically the things is to go for midwife-led maternities in these countries. We have evidence only from the north. We need urgently evidence from the south to see that it's the most cost-effective strategy. Thank you.
Peter, I'd just like to come in and pick up something that Luke said. The ICM midwifery education competencies does describe two pathways. One is a direct entry pathway, and the other one is a post-nursing pathway. So we don't say there is a single route to becoming a midwife. We say there are two pathways, but the common denominator is they must meet the competencies.
Okay, I think I'm going to take them one at a time, and I think maybe we might only have time for one more question because I want to finish up with a question related to the panel topic. Yes. First hand to go up.
Good morning. Carolyn Curtis with USAID. I have one question for Frances, and this is in regard to the current requirements for passing the qualifying exam in countries. In a number of countries that I have visited, generally, and these standards are set by the midwifery and nursing councils, is the pass rate is 50%, is my understanding. And I'm wondering that as we climb the ladder in terms of moving from where we are currently to the professional midwife is whether or not some changes or recommendations could be made with ICM at this point to have those councils take a look at those qualifying exams and be able to perhaps raise the pass rate or raise the standards required for that. I also know that family planning is often not on that. And so we know that with a tight curriculum and all that needs to be taught, if there's nothing on that qualifying exam, then it may be dropped from the curriculum. So I'd just love to hear some comments related to that.
Thank you, Caroline. Interesting questions. That's the whole reason why ICM developed all the standards and resources that it did. And we have been working with UNFPA in the Investing in Midwives program for the previous 5 years. And I've had many successes in several countries where their governing bodies have looked at the standards of midwifery education and what they need to achieve to be licensed to be called midwives. But we haven't succeeded with everyone. But you all can help us because the standards are there, open access on the website. Family planning is number 7 of, no, it's number 2 actually, in ICM competencies. So that's the basis of any good midwifery education program. So it means that those countries are not using our tools and resources. And I would urge you to either signpost it to them, but also see how we can work with them to up their standards, because that's what women deserve. Thank you.
Carolyn, this is particularly important to me. This is a profound problem in my mind, a valid and reliable assessment of our individuals entering the workforce, as well as meaningful accreditation or ensuring a quality of education. So, Frances, I just wanted to say, I really applauded the ICM coming up with the 3 pillars and making regulation one of those pillars. But I was at a large mini university last week, and I heard one of the best presentations on accreditation and licensure based on work being done in Ethiopia for the midwifery profession. There were 3 people that came. Yeah. Out of 300 people, there were 3 people that came. We have to find a way to make the processes of regulation somewhat sexy, because right now it's not, and nobody's listening.
And really, without regulation, everything falls apart. You have to have regulation at the outset to set the standards for midwifery education, to set the practice standards, and to monitor them. Without it, you don't have anything.
Yeah, it's the glue that holds change together. I want to finish with one question for the panelists, because this was about global evidence supporting midwifery. So I wanted to know, and I'll start with Holly, and then I just want to give everybody a chance to, a minute or less, weigh in on what's your advice for setting a midwifery workforce research agenda or a midwifery research agenda? Do we know all the questions now that must be asked? Are there more questions that need to be formulated by midwives and people that care about midwifery? And how do we have sufficient scholars? I think the answer to that was no. How do we interest people that have the scholarly skills necessary that this is a topic worth exploring? So Holly, I'll start with you.
I think one of the most important things we learned out of the Lancet series is that we need to ask different questions, and we need to measure outcomes and processes differently than what we're doing now. So, for example, if you look at population-based data on length of labor or length of gestation, they're different in different populations. And what we've learned is that they are studied and examined within a certain population and then applied globally, and that's probably not appropriate. So that's one area that we need to look at. If you look at the framework, there's just a small part of that framework that is about first-line interventions. Now, yes, we midwives need to know how to intervene when there's an emergency. But more importantly, how do we scale up women's capabilities? How do we support the processes of their bodies that already work very well and know when to intervene and know when not to intervene? And thirdly, how do the way we care for women in terms of respect support their processes of care. There's a new book out that I would recommend to everyone called The Roar Behind the Silence by Byram and Down. And it's about where respect and in maternity care lies. And because if women do not feel respected, they will not access the care. And that's one of the softer calls of midwifery, but it's an incredibly important part. But how do you measure it? And then the last part of your question is how do we prepare the scholarly aspect of midwives? I think regardless of the length or level of education of getting every single midwife to question what she or he is doing and to understand what's the evidence behind that. And if you don't have the evidence, well, then how do you create the evidence? How do you incorporate data into your everyday life? And I think that's something we've separated out. So that needs to be sort of a practical part of the educational process and just the sort of inquisitiveness of thinking about what we do.
Frances?
Many people don't know this, but Holly used to be chair of the ICM's Research Standing Committee. So I know that, and you'll remember that the Research Standing Committee did some research priority work a little while ago, and that's been followed up more recently. So ICM has been looking with the regions to see what the research priorities are for them, and that'll be published soon. But I think we need to come down to a very basic level, and it's to ask the questions why. I think we need to demystify research in the minds of everyday midwives, because research can seem as something far away and distant, and it's those people like Holly who does research. But actually, we all can do our own research, and that's where it starts. So we question what we're doing, we question our outcomes, and we begin small to write that up, even to think about it, and then expand it in that way. We had that discussion in Geneva on the 24th of February with the Francophone midwives, because many countries have not really got a grasp of the importance of research, but they can start small, and I think that's what we should be doing. Ask the question, why?
Luke?
Just one word to complete also, it's part of the collaboration that we have with ICM. Many countries are going to towards the LMD system, master
license master,
system, and this could be challenging for countries, particularly when the tutel of the midwifery education is not under Ministry of Education, but Ministry of Health, or even Ministry of Technical things. There are different type of tutels. So we are pushing for tutels done by the Ministry of Education, moving to LMD, but respecting the capacity of having all the ICM competencies in the curriculum. And it's an opportunity, and I think it will be developed later today, the collaboration that we have with the World Bank to implement midwifery care master in Mali, Bamako, and Côte d'Ivoire, Abidjan, in the coming months, which will be for the Francophone countries in West and Central Africa a very good move to strengthen the education and allow a number of midwives to become trainers and also researchers. So this is a way we are contributing to this, to what you are questioning.
Thank you. Well, thank you, panel, and thank you, Laura, and thank you, Gita, for the opportunity.
Oh, I thought you were asking me a question.